The World Bank did not come to stay. They were coming to upgrade the situation to a standard where we can be self-reliant. So immediately when they withdraw their funding, thinking that we have reached a level where we have amassed what, because there was an indicator on the expenditure for reserves. This reserve was to cater for rainy days. So when they withdraw like that, they handed now to the state. The state could not run it.
Hello everyone, once more welcome to another episode of Africa Health Insight. In today's episode, we look at the differences in care provision between public and private hospitals. And you know, you are part of this community, part of this platform. So we won't continue without acknowledging your continuous support. Tell us areas that need improvement in our content. Also indicate other areas that you want us to discuss. So without wasting much time, I would like my guest to introduce himself and walk us through today's conversation.
Okay, thank you, Elvis. I'm Awah Osbert, a public health activist with specialty in epidemiology.
Yeah. Can you tell us your experience in working in the private as well as in the public hospital?
Thank you very much, Sir Elvis. When we say public hospitals, let's make it clear to our communities. These are hospitals that are provided by the state to ensure that the uniform health care. For private hospitals, we can have private owned by confessional bodies, that's the mission. We have Baptist hospitals, we have Catholic hospitals, we have Presbyterian, and so forth. We have private hospitals for profit making. You know, when something belongs to the state, it belongs to nobody. Then when somebody has his thing as a private something, especially for business, for profit making, you make sure that put in the best. Because if you don't cook your food well, nobody will buy. So the level of care that I see mostly in private hospitals is patient focused. The only loophole there is that you pay a little bit more. Since the government pays its personnel, the cost is cheaper. For private hospitals, they take care of everything. They pay their staff, maybe they pay their structures, they buy their machines for themselves. You are running a business without profit, you cannot control. The cost there is expensive. Patients who have visited this hospital can testify to you that the same cost that they will manage a malaria case in public hospital will not be the same, even for basic primary healthcare activities.
You mentioned something related to cost. How do you think the business model in private hospitals affect the care that they give to patients as compared to public hospitals?
For a private hospital, if they don't manage you very well, they will know that they will lose. So they will want to give their best to return you. Well, they know that when they return you, you preach it to the community and then more people will come. Take on health facilities. First, the technician know that maybe tomorrow he will not be there. Another person will come and take over. And when something gets back there, you report to the state and be waiting whenever funds will be made available for them to purchase. So you will not pay more focus or attention to the patient. That's why many people say that no, even they will not think about the cost. They keep rushing to confessional, to private hospital, where they know that even if they don't have money, they can start up care and maybe pay subsequently. But in our hospitals, if you don't have money, they will not look at you.
Do you think the state-owned hospitals should copy in a way the business model of private hospital? And is that possible?
Very, very possible. The problem with government hospital is sustainability. We had a very good project that was terminated 2 years ago. There is performance-based financing that the World Bank instituted in Cameroon and many other African countries. This was to bridge the gap of conflict of care between private hospitals and government hospitals. The premium that they were paying was the same, was to put these facilities at a certain level so that the community should see no reason why they prefer a government hospital or a private hospital. Because what did they do? They came in, studied the challenges that were in this hospital. If you do not have staff, they will make sure that they give you funds for staff. If your problem was equipment, they will make sure that they supply you with equipment. Even the basics, initially they used to do pre-financing. They give you money to put up the standard of the hospital to a certain level and see how you can bridge these challenges. Then after that, to sustain it, because they know that the machine will wear out, patients will have to grow by longevity, population is growing, you need to add some number of staff. They used to give like premium. You make a consultation. If a doctor makes when they were still pilot, the medical doctor makes a consultation, they will pay additional 1,000. When a nurse makes a consultation, they will pay 250. This was to enable the health facilities not to depend too much on the state, which means that their challenge could no longer be medication. Their challenge could no longer be staff. Their challenge could no longer be equipment. Their challenge could no longer be hygiene and sanitation. or structure.
Yeah.
We have health facilities that have been constructed by this program. Even in our hospital, Kwetise Hospital, you can see there written that done by performance-based finance. Unfortunately, when they left, the project has died down.
What are some of the challenges that led to the collapse of the performance-based financing? Because this was a way to even economically empower the system.
You know, the World Bank cannot do everything 100%. The government had their own part. For example, the World Bank was paying 60%, the government was paying 40%. The World Bank did not come to stay. They were coming to upgrade the situation to a standard where we can be self-reliant. So immediately when they withdraw their funding, thinking that we have reached a level where we have amassed what, because there was an indicator on the expenditure for reserves. This reserve was to cater for rainy days. So when they withdraw like that, they handed now to the state. The state could not run it. We have debts that are standing. The next 2 years that they work, the money has never been paid. So the subsidies now, that the reserves that were amassed at that time, have all been exhausted.
There was a gap identified. They tried to close the gap. It collapsed. Now it looks like we might be going back to the old system where we were. Where do we move to from this particular point?
I think that to the state, they saw the project, they were the one who welcomed the project and implemented it, and they saw the successes.
Yeah.
If there is a way to revisit it and see that it was a good project, we used to have people in the hospital, paupers were managed for free, maternal death reduced, neonatal death reduced, disease mortality generally reduced, because people had no fear visiting the hospital, but they knew that if they go to the hospital, something will be done. It was a very good initiative. If the government can reconsider and see that they bring back this, without necessarily even consulting partners, it's easy. It takes somebody with a good mind. I think that if this project comes back and they put scrupulous measures on how to manage it, we'll move forward.